Welcome. This is a repeat of the September 25th webinar program. Due to technical difficulties, the original live webinar broadcast did not record. Dr. Sean LeNoue, an addiction psychiatrist based at Rogers Nashville location, and Dr. Lynsey Miron, clinical supervisor at Rogers St. Paul, Minnesota location, have graciously agreed to repeat their presentation and answer questions submitted. Now I'll turn it over to our presenters.
Thanks so much, Ruth. Welcome, everyone. Thank you for your time. We're going to be chatting today about treating substance use disorders with comorbid post-traumatic stress disorder, PTSD, and providing some clinical considerations along the way, anything from diagnosis and treatment to certainly also, just general clinical considerations and thinking about treating an individual holistically and making sure that we're addressing their needs. So yeah, without further ado, we'll go ahead and get started. And so here's a quick overview of today's presentation. As far as disclosures go, we have none. Dr. Miron and I are both a part of Rogers Behavioral Health and work with patients and families in different locations. So as far as our learning objectives go, upon completion of today's session, participants should be able to describe at least one way adverse childhood experiences, or ACEs, increase the risk for subsequent PTSD and substance use disorders. We'll also be identifying at least two common misconceptions in the treatment of co-occurring PTSD and substance use disorders. And then we'll also be listing and describing at least two evidence-based treatment modalities for co-occurring PTSD and SUD, substance use disorder. So what we'll be covering overall? Well, we're going to look at epidemiology, including prevalence of these issues in adverse childhood experiences, or ACEs, and related prognosis. We'll also be looking at risk pathways and assessment, including co-occurring models and what that tells us about approach to treatment and how that guides and informs best practice. And we'll also be, again, looking at that assessment of comorbid issues. And then that will certainly in turn roll into treatment and thinking about common misconceptions, as we've mentioned, and then research findings and overall practice recommendations. So we can go ahead and get started with epidemiology then. So when we look at prevalence, we know that trauma, as per the American Psychiatric Association per DSM-5, trauma is defined as exposure to actual or threatened death, serious injury, or sexual violence. And that we know that psychological trauma is typically defined by a broader scope. And I think that certainly we use this definition as a framework in our understanding and approach, but overall we know as well that trauma is not limited to just these issues, and that the way in which trauma affects individuals can be quite vast and varying. We know per the literature that exposure to a traumatic event is common in the United States, and that in our country, over 50% of women and 60% of men report at least one lifetime trauma that they have experienced or endured in some way. And that we know witnessing a significant injury or death is the #1 type of trauma most frequently reported. And that also involvement in fire, flood, or natural disaster is fairly common as well. In addition to, then exposure to life-threatening accident or an assault, gunshot, or a fall, or other typical types of trauma that are reported. When we think about post-traumatic stress disorder, PTSD, this is per national studies that are regularly conducted and monitored. So in adults, we'll break it down, adults and adolescents for PTSD. In adults, we know that 3.6% of adults report past year symptoms that meet criteria for PTSD. And when we further break that down, 5.2% of females versus 1.8% of males, adults in the US past year are exhibiting features consistent with PTSD. We overall know that lifetime prevalence of PTSD for adults in the US is approaching 7%. And that's based on self-report. So, while we don't know exactly if that number is higher, it definitely seems that it's possible that, given this is self-report, that it could be higher. Then we're talking about, roughly 5 to 10%, somewhere in that range, of individuals that are adults in the US have experienced and display symptoms of PTSD, which is significant. Adolescents, breaking that down, we know that overall prevalence there is 5%, and we see that 1.5% of adolescents display severe impairment related to PTSD, and that's going to be, when we kind of break that down, thinking about overall functionality, quality of life, the way in which these symptoms and issues are then affecting an individual's ability to adapt, to function, to cope, to exist in many ways. And so we know that the individual, but also families and communities, are affected by these issues too. For adolescent females, we see that 8% typically experience or have some sort of trauma that then leads to PTSD versus about 2.5% of males. So moving on, substance use disorders. We're going to break this down again. This is US data broken down by adults versus adolescents. We're looking at 12-month prevalence here for substance use disorders. And we see that in adults, 12% roughly of adults will meet criteria for an alcohol use disorder in the past 12 months versus illicit substance use being about 2 to 3%. And that's a broader category. Again, these are self-report. 12-month prevalence for adults with substance use disorders. Compared to adolescents, 12-month prevalence of alcohol being about 8%. And illicit substance use is actually similar overall there, with about 2 to 3% of adolescents meeting criteria for substance use disorder of illicit substances in the past 12 months. When we look at PTSD and combined substance use disorder, we see that these issues are highly comorbid. And we know that regardless of exactly, which comes first, the trauma and PTSD versus substance use leading to a substance use disorder, we know that one can certainly beget the other, given risk factors and the way in which each independently negatively impacts an individual's life. And then certainly the effect becomes compounded and can certainly lead to one another. So, with the example being that if someone endures a type of stressor and trauma, which then can lead to PTSD, we know that by meeting criteria for PTSD, that certainly symptoms are significant enough to impact quality of life and functioning. And then it's not uncommon, not for everyone, but it's not uncommon for individuals then to go and to potentially self-medicate through the use of substances in order to be able to deal with the trauma and subsequent symptomatology associated with that trauma and PTSD. So highly comorbid, approximately 50% of individuals with PTSD also have a substance use disorder. And we know that comorbidity overall of these issues and conditions is associated with more severe PTSD symptoms. And that's likely from a variety of reasons, including potentially self-medicating, as was discussed. And then also increased risk for substance relapse after treatment. And so we'll talk more about this. We're talking about prevalence right now and overall effect, but certainly that ties into where we'll be getting later on in today's presentation and discussion of how more severe symptoms can lead to greater risk for comorbidity. And then with that comorbidity, that ties into greater risk for relapse and subsequent use. So the cycle can really build on itself. So overall, we'll talk about why it's so important to address and to treat all issues concurrently, and more to come there. Prevalence, when we think about adverse childhood experiences or ACEs, we know that these issues are common, particularly in the US, where approximately 60% of US adults have reported experiencing some type of adverse childhood experience earlier in their life. And we know that 1 out of 6 individuals here have reported at least 4 or potentially more adverse childhood experiences in their lifetime. When we break that down and we think about who is potentially most at risk, and we think about vulnerable populations with the intent there of being able to try to identify and intervene earlier to try to ultimately, ideally, prevent these issues from ever occurring. We know that women and individuals of racial or ethnic minority groups tend to be at greater risk, particularly for having multiple adverse childhood experiences. So all the more reason there of thinking about, and we'll talk about this, potentially more in the treatment section, but of just early identification, working on, the best treatment being prevention, right? And trying to think about how we can help all individuals in our community and being able to lead healthy, successful, productive lives. And part of that is going to come through community intervention and support to be able to help individuals. We know that increased risk for injury, sexually transmitted infections or STIs, teen pregnancy, sex trafficking, chronic illnesses, and suicide are all associated with, and there's an increased risk for these issues when there are, these adverse childhood experiences that come on either at the same time, or then the risk for these subsequent issues can come later in life. And so when we think about the impact overall that these issues have on families and communities, and frankly, goals, wishes, desires, and dreams, really, there are a variety of different really important facts and data and figures out there. But I would go so far to say that, really it's incalculable. We can't put a number on the significant impact that this has on all of us, right? Because these are not issues that pertain or affect just the individual. They certainly do, and oftentimes in really significant ways, unfortunately. But the point being there is that in addition to that these issues affect families, they affect communities, they affect us all. Right. So this is not an issue of a certain person or a certain group or a certain place. These are issues that we all face and that impact us all. And so, turning that around then and thinking about from a place of hope and collaboration, like how can we all come together to support one another, to ultimately lead healthy, productive lives individually, which in turn can then translate into healthier communities overall. So taking care of one another is certainly so important. When we think more about adverse childhood experiences here, we know that these experiences negatively impact a person's well-being and often have lasting effects. Okay, and we see this too clinically and in the research and in the literature, that there can be not only impacts on the individual and the family, friends, community, but that these issues can transcend time, specifically with affecting generations of individuals. So a trauma, significant issue affects that person throughout their lifetime, and it affects their family and potentially their children, right? And that can affect their children's children. And so while that is quite unfortunate, there's also a plethora of opportunities here for intervention and to be able to turn things around. So those issues, while they are significant and they are quite unfortunate, there's also a lot of opportunity to be able to intervene, like I mentioned, not only through prevention, but with good treatment as well, to be able to reduce and eliminate the impact that these issues and these adverse experiences can have over time, right? We know that domestic violence, family members struggling with substance use and or mental health issues, and child abuse and neglect are significant. And that, you know, these are only some of the ways that individuals are initially impacted and impaired, and that, you know, having a conversation, I would say, is a really great place to start about, you know, identifying if there are concerns about an individual's safety, or if they're potentially experiencing trauma, of being able to have that conversation, to begin that dialogue and discussion, so that people know if they're in a really difficult situation, number one, that they're not alone, and that people care, but also number two, that we can help, and we can hopefully really try to intervene early to turn around someone's experience in their life. So we also know that there's a strong relationship between non-sexual child maltreatment and a whole host of different mental health issues and disorders, drug use, suicide attempts, STIs, as I mentioned before, and risky sexual behavior, which certainly has a variety of different implications, not only for an individual's mental health and physical health, but also from a public health standpoint and concern. And we also know that these issues can then, you know, for a variety of different reasons, potentially lead to repeated victimization. So the cycle really continues. So again, early intervention and identification and having that conversation can be so important to be able to break that cycle and not repeat these devastating issues. When we think about prognosis here, we know that individuals with co-occurring issues suffer from a more complicated course of treatment, and that we see that less favorable treatment outcomes, you know, are often obtained compared to individuals with either disorder, you know, individually or alone, right? So the takeaway there is that the combination of these two major issues and concerns makes treatment more difficult. Not impossible. It's not to say either that we don't see good outcomes with these co-occurring issues, but they're complicated. So all the more reason why early identification and intervention, and ideally prevention, is so important to prevent any issues from coming up before they happen. But if they do, that through early identification, to be able to intervene to hopefully slow, stop, reverse the progression, and certainly aid with, you know, symptoms and issues not progressing to a place of great severity, which then, you know, continues to negatively impact the individual and make treatment more difficult. So, you know, overall, just why is this complicated? Well, we see that, you know, from the trauma and substance use itself, there's those direct and then indirect factors that go on to negatively affect the individual, with increased chronic physical health problems, overall poor social functioning, higher rates of suicide attempts, and more legal issues and problems potentially, in addition to increased risk for violence and just worse treatment adherence. And that's not surprising in a lot of ways, right? If you have someone who has sustained serious trauma and abuse, who may then use substances to cope, and then, you know, are not able to work, take care of themselves, their family, their physical health, you know, they're really just struggling to survive more than anything else. And so the other things that many Americans day to day are thinking about and working on, whether it's, you know, savings, retirement, you know, promotion and progression and a career and a job, and taking care of their family and their children, you know, these sadly can be an afterthought or not even a thought at times for individuals who are struggling with these really severe issues, because again, they're merely trying to survive. And so the more that we can do to help them, certainly the better. And, you know, this is just an overview and an adaptation from research and literature of when we think about prognosis. we think about, these different pathways of, well, why is it complicated? Why are these issues so broad and vast? Because we know that PTSD and substance use then can go on in sort of a cascade effect in fashion and can affect the hypopituitary adrenal axis. So that's the part of our nervous and endocrine system that's involved with our autonomic nervous system, the fight or flight part of the nervous system. We see that cortisol levels can go, very high through the roof. That can have, immediate and long-lasting implications on a person's physical and mental health and well-being. We also know that physical injury can be sustained not only from the trauma and abuse, but also, falls or injury related to substance use or complications related to injection substance use or drinking and falls, right? And then poor overall health behaviors. So people aren't taking care of themselves right now in the moment and then long term, and what that can result in. Not only that, but there can be chronic issues like hepatitis C from injection substance use that, in this day and age, we now have very robust and effective treatments that can cure, in some cases, some of these physical issues. But if a person is really in a very difficult state of mind and place of being, they may not have drive or desire or knowledge of these, life-changing and saving treatments, so that then these issues which had, frankly killed individuals and shortened their lifespans, like hepatitis C, those issues which we can now treat then persist and negatively impact. And this really all comes back down to there's a cascade out in a way that negative impacts are created and sustained, but they all sort of come back together, as we see here, with poor physical and mental health. But again, lots of opportunities here to intervene, to help an individual to turn things around. We know that complicated issues lead to complicated disorders that can be chronic and relapsing and remitting, not only when we think about mental health and PTSD and symptomatology, but certainly if substance use develops more into an addiction, right, where we see that an individual really struggles day to day to work on achieving and maintaining sobriety. We also know that these can be difficult, as I mentioned, to treat due to the complex nature of the illness or illnesses. And these require, again, a multifaceted approach with oftentimes it's not uncommon that we have to utilize a variety and multiple evidence-based psychotherapeutic modalities, as well as possible evidence-based medication treatment modalities, not only for mental health and substance use, but then again, as I mentioned, like in the case of hepatitis C, medicines and different medications to treat physical issues as well. So really, this is a multi-layered, multifaceted approach, and the more that we can collaborate with the patient and family, but also providers and therapists and different community resources to think about overall recovery. And that's not only recovery from substance use, but also mental illness and physical health and well-being, just broadly speaking, recovery. That is achievable, but it is certainly a group effort. So now we're going to talk about risk pathways and assessments, and I'll turn it over to Dr. Miron.
Thanks, Dr. LeNoue. All right, so I'm going to spend a little bit of time talking about, now that we know that this comorbidity is so common, why is this comorbidity so common? How can you as a provider conceptualize why these two disorders are co-occurring for your patients? How can you help your patients potentially think about the different pathways that they've been on or potentially are at risk to be on in the future? And then we'll spend some time just talking about assessment, early detection of a possible comorbidity, diagnostic instruments that can be used for more thorough clinical assessment and interview, and then also how to track any progress that you're making in treatment, and whether there is, ongoing substance use or PTSD symptoms over time. Okay, so again, we know that these two disorders co-occur. The question that remains then is why? The answer is, as most things in psychology, complicated, multifaceted, a lot of it depends, and both answers are correct. So I'm going to review 4 common co-occurring models that researchers have used to explain this comorbidity, with the caveat that these models are not mutually exclusive. And we can also talk through some examples that illustrate that many of these different models may be interacting and multifaceted for any given patient. So the first model I'd like to talk about is the self-medication model. This is probably the model that patients have the easiest time understanding. And certainly as providers, we could understand how this model makes sense. So this model essentially asserts that having PTSD, the specific symptoms that go along with post-traumatic stress disorder, would make somebody more likely to develop a substance use disorder because substances are used explicitly to manage the symptoms of PTSD. So if we think about some of the research that's been done related to this model, there's actually something quite unique about PTSD and that diagnosis in particular, as opposed to trauma exposure in general. Dr. LeNoue talked a bit about the ACEs, and just because somebody experiences an adverse experience in childhood or a number of those different risk factors may put them at risk for a substance use disorder, but it doesn't necessarily mean that they will develop PTSD. This idea that you can have trauma exposure and develop PTSD or not, or depression or not. But for this model, we're really looking at that PTSD diagnosis. And there has been some research showing that individuals who do develop PTSD are at a higher risk for substance use disorders compared to individuals who are exposed to trauma, but do not develop PTSD. So again, that PTSD diagnosis is the crux here. And if you think about the different symptoms of PTSD, this makes a lot of sense. So in particular, if we think about re-experiencing symptoms, for example, nightmares is an example that I'll hear a lot clinically. Substance use may be utilized in order to reduce the likelihood of experiencing a nightmare while sleeping. If we think about the avoidance symptoms of PTSD, certainly substance use fits nicely into kind of that maintenance, where substances are used to kind of block experiences and aid avoidance. Certainly the hyperarousal symptoms of PTSD are a strong link with substance use disorder, where an individual may have a difficult time calming down enough to get rest, get relief from their symptoms, and substances may be used as a method to essentially calm the body down enough in order to function. So again, substance use directly tied to the management of very specific PTSD symptoms. Another model that's commonly used to describe this comorbidity is the shared liability and mutual maintenance model. This essentially asserts that the risk factors for both disorders, PTSD and substance use disorders, are the same. And they're shared and mutually maintain both disorders. So if you think about some of the risk factors we've already identified in our presentation today, genetic factors, family environment, those certainly could underlie both disorders. Things like the use of avoidance is common across both disorders. So the shared liability model, both disorders have the same underlying risk. Moving on to some other common models, one being the susceptibility model, which asserts that early stress exposure leading to PTSD would make people more vulnerable to develop a substance use disorder later on, or that the increased anxiety and arousal that often accompanies chronically using substances may increase the biologic vulnerability to developing PTSD. So one makes the other more likely to increase susceptibility. The final model I'll discuss is the high-risk model. This essentially is demonstrating that substance use or abuse increases risk for trauma exposure by placing individuals in high-risk situations. So, for example, drug-related crime. This model generally gets at the lifestyle of a substance abuser, which could involve time spent in high-risk situations or environments, is going to make someone a lot more likely to potentially experience trauma for the first time or re-experience trauma, a re-victimization, for example. So these are the four most common models. Of these four models, the most evidence exists for that self-medication model, that substances are used to cope with and manage PTSD symptoms. And there's plenty of research to also suggest this. PTSD has been shown to develop before a substance use disorder in most comorbid cases in retrospective studies. What that means essentially is studies where we're kind of looking back at and asking people to think about, when did this develop? When did you first notice this? Most research participants would say that PTSD came along first. There's another more sophisticated way that we can look at this, and that's using prospective studies, which would essentially mean that we can track the same participants over time. And if we're looking at a group of participants who have a diagnosis of PTSD with no substance use disorder, and we follow them for an extended period of time, years or even decades, those that have that PTSD diagnosis are a lot more likely to develop a substance use disorder later on. There's one study in particular that found that for each additional symptom of PTSD, risk for an alcohol or drug-related problem increased approximately 10%. So if you're familiar with the PTSD diagnosis, there are a number of symptoms, which really highlights just how much these symptoms are driving substance use or risk for some kind of substance use disorder. Again, these models are not mutually exclusive. They can be integrated into a larger conceptualization of developmentally what sets someone up for risk for this comorbidity, or how can we think about somebody's relative risk in the future. So for example, we may have somebody who had pre-existing substance use problems in adolescence. And because of the scenarios, environments, contexts, social circles, they may find themselves, in order to acquire those substances or to use those substances, that individual may be at greater risk for trauma exposure. So that really ties in the high risk hypothesis. If that individual develops PTSD from that trauma exposure, from those high risk contexts, they may be a lot more likely to use the same substances or even different substances to manage those symptoms of PTSD. So that would really tie in the self-medication model. So again, it's complex and multifaceted, but certainly not mutually exclusive. Overall, could you go back to the other slide? Thank you so much. So overall, the high risk prevalence suggests there is something common etiologically that underlies both of these disorders. One thing that I wanted to talk a bit about is the added impact of stigma and minority stress specific triggers. So if we think about the pervasive and quite long lasting impact of stress and discrimination or overt racism on the body and the brain, particularly for minority populations, communities of color, LGBTQ plus communities, this chronic stress state can lead to altered amygdala resting state. So the part of the brain that detects threat, and can lead to this state of kind of chronic hypervigilance, being chronically alert. So you can imagine that that would contribute to both PTSD and potentially to substance use disorders to manage that chronic stress state. So overall, there seems to be a lot of common factors that would set someone up to be at risk for these comorbidities, in part due to how our bodies react to stress, and how our environment shapes our behavior. So now that we've talked a bit about some of the models that help explain the comorbidity, I'd like to spend some time talking about how do we go about assessing and then later in our presentation treating this comorbidity. The thorough assessment of symptoms is a really essential component of effective treatment for PTSD and SUD. And your assessment procedures may involve a number of steps, ranging from that initial screening that could occur in a number of different contexts, potentially a primary care appointment, could be in a specialty clinic for the other disorder, for example, in a trauma clinic or a addiction recovery program. Procedures would also then involve a more lengthy diagnostic interview and then monitoring. And that typically is used in the form of self-report, but certainly also biological tests. So we'll talk about each of those. The primary goals of assessment are to detect, is there some trauma history? Is there any kind of life event that could lead to PTSD or could influence the use of substances? And on the flip side, is there substance use, and is that substance use problematic enough that it warrants attention clinically? Another goal is to evaluate specific DSM-5 diagnoses. And then, of course, ongoing assessment of symptom severity and treatment progress throughout the course of intervention. So regarding initial screening, there are several brief tools that have been developed to screen for exposure to trauma in substance use disorder. So we'll talk about each of these and where you might be able to find these measures and what populations you can use these measures with. So to start with substance use disorders, some of the most widely used, and I would recommend screening tools, include the Alcohol Use Disorders Identification Test, the audit. This test is verified for use with anyone 16 years old or older. A really brief measure that would look at substance use frequency, severity, but also problems that may have occurred because of substance, specifically alcohol use. Similar to the audit is the DAST, the Drug Abuse Screening Test. Again, this one is validated for use in individuals 16 years old or older. And then certainly any biological tests for alcohol and drug use. So that could be a breathalyzer, for example, a urinalysis, for example. Anything that you might have access to could be helpful at this stage, particularly if that rapport and trust hasn't been developed yet enough for patients to talk about this freely and openly with a new provider. Regarding PTSD symptoms, or even, I guess at this point, trauma exposure in general, there are a few tools, most of these developed by the National Center for PTSD, that can be quite useful. One is the Primary Care PTSD Screen for DSM-5. This is exactly as the name suggests, developed for use in primary care setting, very brief instrument that could minimally tip someone off to, oh, there's a trauma history here, possible PTSD symptoms, and it would be helpful to follow up. Most often used in our clinics anyway is the PTSD checklist for DSM-5, or the PCL5. This is a brief inventory of all of the PTSD symptoms, and we typically would utilize this measure in addition to something that's not on this slide, but I'll share the life events checklist. All of those instruments are available at the National Center for PTSD website, which is at the end of our webinar, the last slide today. So moving into diagnostic interviews. So after your initial screening, you've gotten some indication that there may be substance use or a trauma history. You'd want to move on to more advanced assessment procedures in order to really establish, is there a diagnosis here? So these instruments certainly take longer than the brief assessments and generally need more training to administer. Some of the diagnostic interviews that I would recommend are the CAPS-5 for PTSD. So this is the clinician administered PTSD scale for DSM-5. It really is the gold standard in diagnosing PTSD. This is also available at the National Center for PTSD website. In terms of a diagnostic interview for a substance use disorder, I would recommend the Alcohol Use Disorders and Associated Disabilities interview, Schedule 5. This is just going to give you more information about frequency, severity, and consequences of use, and ask different questions across different substances that somebody might be using. I've got a few other options on here if these instruments are more familiar to you. A lot of individuals I know utilize the SCID, the Structured Clinical Interview for DSM-5. And if you are familiar with the SCID, you know that it's quite long. So certainly if a full SCID isn't something you could easily schedule into your practice, specific relevant modules could be used in instead of the entire SCID. So the PTSD module and the substance use disorders module. And then finally, the mini international neuropsychiatric interview could be utilized for either of these disorders. And then finally, in your assessment of the comorbidity, you'd want to develop some way of tracking these two diagnoses, symptom severity over time. So again, I think the PTSD checklist for DSM-5 is a great instrument to use. It tracks all of the symptoms of PTSD in one quick instrument. Another instrument that we use a fair amount is the timeline follow back. So can we get a picture of someone's use over time? The brief addiction monitor, again, a good way to track symptom severity and progress in treatment that relates to substance use. And then ongoing biological screening. Some other things I'd like to just mention that aren't on the slide here, but I think are worth mentioning are other targets that you might want to consider when you are assessing this comorbidity. Specific to substance use disorders, you would want to think about, when did this patient first start using drugs or alcohol? What is their substance of choice? And how often and what substances do they use? So really getting a clear picture of going through each of the different substances that they might be using. Which are they using now? Which have they used in the past? If they've had any treatment, that would also be really important at this point. So have they received treatment in the past? And if so, what was the outcome? Any family history of drug or alcohol abuse, their relationship status, and if there is any significant use of drugs or alcohol in that relationship, and whether they attend any community meetings or have any additional community supports. In addition to assessing for PTSD symptoms, some other common comorbidities that would be worth thinking about in this case are also depression, and how might depression, substance use, and PTSD kind of all be linked for that particular patient.
All right, thank you, Dr. Miron. We'll now transition and move into treatment. And we'll start with talking about some common misconceptions. And Dr. Miron, if you're up for it, maybe you and I we could tag team some of these and talk about it. So we'll jump right in. I can start with the first one here. So if I ask, these are common misconceptions. So the first one being, if I ask a co-occurring patient about their trauma, they are going to relapse and get worse. That's something that I hear frequently, and I think it's certainly understandable why this is a misconception, because of sometimes the really difficult place that an individual is in, and when they're really needing treatment. But what are your thoughts about this? So asking about trauma will lead to relapse and things getting worse.
Yeah, I see this as a pretty common factor that may make someone reluctant to go there with a patient. It's like, I don't want to open Pandora's box. I don't know what will happen, and this patient might not be able to handle it. I do think if we're thinking about, for example, the self-medication model that I just mentioned, patients with co-occurring PTSD and substance use disorders are experiencing PTSD symptoms every day, and they're likely thinking about their trauma every day. Whether they're awake or sleeping, that trauma is very constant and present for that person. So it actually, it isn't necessarily Pandora's box. They're already thinking about that quite a bit of the time. Could we think about that in a different way that might actually bring that individual an incredible amount of relief? So I would say to this misconception, no, not necessarily. It is true that PTSD symptoms tend to elevate somewhat at the beginning of trauma treatment, but very quickly we see those symptoms reducing. So I guess preventing this treatment from occurring, that's probably how this individual would be more likely to relapse and get worse.
Yeah, and if I'm hearing you, Dr. Miron, it's almost like creating a safe space to allow for a discussion of the things that the person is already probably thinking and feeling.
Correct. Yeah, absolutely.
Yeah.
So I'll jump into this next common misconception. So this is the idea that a patient is not going to fully benefit from trauma treatment unless they abstain completely from substance use. Any initial thoughts on that, Dr. LeNoue?
Yeah, I mean, also understandable why this is a misconception, and we hear it frequently because, again, I think it speaks to the delicate and complicated nature of the issues that are being addressed. And, you know, the reality is that in an ideal world, I don't disagree. Like, you know, someone not using substances in treatment while they're trying to address trauma-related issues, that would be ideal. And I think that's definitely what we would see in many research models, and it's understandable, right? Unfortunately, we don't live in that world, right? And because if we were in an ideal world, well, there wouldn't be trauma, right? There wouldn't be substance misuse and abuse. But the reality is that we don't have to live in that ideal or perfect world in order to really be able to address these issues right here, right now with patients. And I think it's all about the approach and how we go about starting to broach these issues with patients and sort of normalizing that what they're experiencing is not uncommon, in the sense that we want to validate where they're coming from, and that their experience is unique and certainly their own. But a lot of times there can be a lot of shame and guilt that goes along with trauma, and certainly substance use and that comorbidity there, you know, it can be exponential. So normalizing in that these issues, when they come up, that they commonly occur together, and that there are things that we can certainly do to address them. And I think, you know, for a long time, treatment models have been focused on trying to compartmentalize, you know, like, well, first we need to treat the substance use issue, or first we need to treat the trauma, PTSD. It's understandable, but we also, I think, have seen over time more and more too that sometimes it doesn't work, and sometimes it's also just not as robust and effective as addressing the major comorbidities at the same time, because the reality is that there is synergy in not only how PTSD and trauma and substance use affect one another and symptoms can worsen, but also as we start to pull those things apart, there is synergy in how we can make gains in different domains of treatment related to trauma, mental health, and substance use, that as we get substance use under better control, not even perfect control, but better control, that's going to help with an individual to be maybe more present, maybe more of sound mind, to be able to address these issues related to their mental health and PTSD. And then as we make gains in that domain of mental health, and we can hopefully help to teach skills, then we can also, utilize other means of coping rather than substance use, right? And so they really can work hand in hand from the clinical work that we see and do at Rogers.
I completely agree. And I also think about when we think back to those prevalence rates that you shared earlier in the presentation, if we are waiting until someone is completely abstaining from substance use to start trauma treatment, that's a lot of people who probably aren't getting care. And if we know anything about how addiction works and how kind of the model and stages of change, it's not this linear process where, okay, now you're ready, you're done, you're no longer struggling with that addiction. Now you're ready for trauma work. So I think, as providers, we would be doing a large number of patients a disservice if we were waiting for kind of this ideal situation to materialize.
I agree. And I would just add very briefly here too, that if we think about this from a medical model too, like if we have someone with high blood pressure and diabetes, right? And we know that one can affect the other, no doubt. If we were to take on that model of, well, we're going to really try to optimize your blood pressure, great, love it. But we're not going to try at the same time to address your diabetes. So blood pressure is looking better and better all along the way. But in the meantime, blood glucose, diabetes is just wildly out of control and really can undermine the treatment of the hypertension, right? So it's a simplistic model, but I think it rings true and resonates here too, that in many other models of medicine, we wouldn't treat issues at the same time because we know that they affect one another. Even more so why we should do that here. Yeah.
Yeah, great point. Another common misconception, I think, has to do with the population that that we're serving by thinking about this comorbidity. So the idea that patients with co-occurring PTSD and substance use disorders, they just don't respond well to treatment. So maybe they wouldn't be a good fit for these highly structured evidence-based treatments for PTSD, for example. Some initial thoughts I have on that are, I can see why this is a common misconception. This is a more difficult comorbidity to treat than if we had either of these disorders occurring without the other. So there is some, I guess, underlying rationale here. However, there is a lot of research suggesting that patients with co-occurring PTSD SUD can respond very well to treatment. Perhaps it would be more difficult than if someone had a cleaner diagnostic presentation, but it's certainly not rationale to not give it a shot. And there's good evidence that treatments can be effective.
Totally agree with you again, Dr. Miron, in that, I don't know that many would argue that the work would be easy. It is hard work. It's challenging work for, the treatment team. I would also argue that it's even more challenging for the patient, for the individual. And so, when we approach individuals with that compassion and just trying to meet them where they're at, it will likely be hard work. I think also too, there's oftentimes a lot of opportunities to be able to optimize treatment models too, right? Because we have to think about not only how our therapeutic approaches work, but we've also identified that these are multifaceted issues, right? So that it's likely going to take a multifaceted approach. And so how are we designing and utilizing the best possible program and infrastructure and delivery model that can adapt and adjust right along with patients and providers to be able to meet those needs. I think, you know, that we should totally acknowledge that yeah, this is tough, and that can be a driving force for why we've got to use the best tools and instruments and approaches that we can. But that's not going to be good enough, because we've got to continue to evolve as well, which is one of the many things that I so appreciate about the Rogers model, and that, you know, constantly we're trying to evolve and improve to be able to provide the best care today and even better care tomorrow. So it's good work and it's hard work. Yeah. Well, we'll look at treatment, looking at research findings. I believe, Dr. Miron, were you going to start us off here?
Yeah, I would be happy to. So we've alluded towards this, but historically, the standard of care has always been we treat the substance use disorder first, and we're going to defer that trauma treatment until that particular patient is ready. We would call this the sequential model of treatment. Treat one, then you treat the other, and usually the one you have to treat first is the substance use disorder, which makes sense. These are both highly disruptive diagnoses, but a substance use disorder typically has an even more kind of acute presentation that would warrant treatment. We are really in a better place now than we've ever been in treating this comorbidity. And in part, that is because there's a lot of research suggesting we don't necessarily need to follow this sequential model of treatment. We have effective treatments that treat these disorders simultaneously that are available. Or can someone who's used to treating one or the other start to integrate consideration of the other disorder into the work that they're doing with that patient? So there's a lot of data showing that treating this together is helpful, and it really helps people recover. There's some other more qualitative research suggesting that patients really like the model where they can treat both things together. And if you think about those different pathway models we discussed earlier, that makes sense that a patient would want to treat these together, because in their minds, they're probably quite linked, particularly if they are using substances to manage PTSD symptoms, or in order to manage a difficult family environment, for example, or a traumatic, stressful, chaotic family environment. Treating these together makes sense. It doesn't make sense to parse them apart. So there are some effective treatments that address PTSD and substance use disorders simultaneously. There are others that address them individually. I'll try to talk about both of them, but really those integrated approaches are fast becoming preferred and really recommended. So I'll talk a little bit more about these integrated models of treatment. Again, these models are acknowledging that there's a complex interplay between the symptoms of a post-traumatic stress disorder and a substance use disorder. There's some utility in having both of these disorders targeted by the same clinician, by the same clinical team. And again, this is a lot more closely linked with that self-medication hypothesis, which would suggest, okay, so if somebody is using substance use disorder, substance or any kind of substance to manage symptoms of PTSD, if we're just treating the substance use disorder, the PTSD symptoms remain and are probably going to pose a great risk for relapse unless someone's able to develop really good coping strategies for managing PTSD. What we know about treating PTSD is that it's really effective, and people don't have to live with those symptoms. So truly the best way to manage PTSD symptoms is to get trauma-focused treatment. So again, this method of treating them concurrently, not sequentially, is preferred by the vast majority of patients. Talking a little more about specific research that supports these integrated models, we have found through research that when PTSD symptoms improve, problems related to substance use disorders also improve. Even without targeting substance use specifically, if I have relief in this area, I'm going to have relief in this other area. The reason that this is really highlighting the integrated model is that the reverse is not true. If you treat a substance use disorder first, PTSD symptoms generally don't move, they don't get better. So kind of a long story short here, trauma treatment really should not be delayed because it has such an important influence on that patient's quality of life, but also it's really, you know, two birds with one stone. We can't really wait to treat the substance use disorder if that person has a comorbidity, because treating the PTSD is really going to give us the most bang for our buck and get that individual relief sooner. Next slide, please. So the next slide should be coming up quickly here, but I will talk a bit about specific practice recommendations. So there are a few models of protocols that already exist that integrate treatment. Again, that being the most preferred by patients and currently having the most research support. So one is called the COPE treatment. It's concurrent treatment of PTSD and substance use disorders using prolonged exposure. So if you're familiar with evidence-based treatments for PTSD, prolonged exposure as a CBT-based treatment that has, if not one of the most research evidence suggesting that it is effective. So this is essentially a treatment that combines PE with monitoring substance use over the course of treatment, and also integrating different strategies for managing cravings, for example, setting goals related to substance use. So a truly integrated treatment. Another that is less exposure-based and is typically used in a group setting is seeking safety. And then another integrated CBT treatment is ICBT, integrated cognitive behavioral therapy. There are also less formalized approaches to integration that could have some utility. You might be able to integrate some of these practices into what you already do with patients without necessarily changing to follow a different manual like COPE, for example. So really, if you're someone who is already engaged in trauma-focused treatment, you might consider integrating substance-related topics. So how do you help a patient recognize and effectively manage triggers for cravings? How can you help them recognize and manage high-risk thoughts about using alcohol and drugs? For example, oh, I'll just have one. Can you teach that individual effective coping skills like drug refusal skills? And how can you help that individual to track and reduce their use over time? Again, that might not be aiming for abstinence if that individual is not interested in that, but maybe it is reducing their use to a rate that is considered low risk. So this is a randomized, actually a review of a number of randomized controlled trials that evaluated treatments for this specific comorbidity that we've been talking about. I wanted to highlight some of the results from this Simpson and colleagues study from 2017. I like the name of this study a fair amount. It's called No Wrong Doors, Systematic Review of RTCs that evaluated treatments for comorbid PTSD SUD. So no wrong doors. It's saying that really we can't, there's utility in trying to integrate treatment no matter what. Basically that participants benefit from nearly all of the treatments that were tested. So the treatments that we're using already, they're effective. If we want to integrate consideration of trauma or consideration of a substance use disorder, there really is no wrong door. However, they did find that when they used an integrated exposure-based treatment, so that would be similar to that prolonged exposure cope intervention that I mentioned earlier, that really had the greatest effect. So the conclusion from this review is that if you have the option to utilize an integrated treatment that uses exposure therapy, that is going to be the recommended way to treat this comorbidity. However, if that's not an option for you, any of these other models or any of these other interventions in whatever capacity you can integrate both are going to be beneficial for patients.
All right. Thank you, Dr. Miron. We're going to continue moving forward with practice recommendations and just some general thoughts and guidelines about what can be helpful. And first, just being particularly in this area and with these comorbid issues, we really just want to start by meeting patients where they're at, right? Because there's already a lot of shame and blame and judgment and guilt that's there oftentimes. And so, I think especially, from a substance perspective, some patients are going to be interested in an abstinence only model. And, and that may even include not taking any medications to help with abstinence. And while that's not going to necessarily be the most evidence-based approach, we want to meet patients where they're at because, and we'll talk about it later on in this slide, but something is better than nothing, especially when we talk about building the momentum of treatment and recovery. Whereas other, patients are going to focus on abstinence. We said others here, they may want to just focus on reducing their use. Again, maybe not the most ideal, but, whenever someone is in a mindset of like, hey, I'm using IV heroin and I'm thinking about wanting to cut back or use less or whatever it may be, I'm always going to take that as a place to start clearly and wanting to build on that. We know that goals can vary across different substances used, thinking about like drinking alcohol, for example, versus an injection substance use. And this goes to bring up, I think, an important point, especially on the substance treatment side, is that, urine, salivary, other types of drug screening tools are often used and should be used. They're evidence-based and they help to guide and inform treatment. But I think it goes back to, guiding and informing. We as providers are not the police. We're not trying to be the police. It doesn't mean that we're not trying to hold patients accountable to themselves and their recovery. Absolutely. But we don't want to set up an adversarial relationship, and we don't want to set up a relationship where, sort of 3 strikes and you're out sort of mindset, or we're looking for people to fail. We're looking for people to engage, and we're looking for people to want to embrace the struggle, frankly, that is going to be recovery on some level, but also number one, to know that they're not alone and that recovery is very real, and that while it definitely takes time, we can see some pretty tremendous gains even early on. So the way that I think about utilizing urine drug screen testing really is just going to be an opportunity to acknowledge and reward someone for a job well done. And sometimes that frame and mindset can even be, okay, you're still continuing to use marijuana, for example, but we're seeing that your levels and the values are coming down. Now, clearly, we're still going to aim for no use, but you're not using more, or hey, you have been using 3 or 4 substances concurrently. You're down to 1 or 2. Clearly, more work to be done, but we're moving in the right direction, I would argue. So meeting patients where they're at, we start with that, and then from that, we really build on trust and rapport, which is so essential for both of these treatment processes. And when I say both, about kind of trauma, mental health, recovery, and substance use. And really, I think we distinguish and we compartmentalize in some ways, I think, because that's how our minds are sort of hardwired and built. But really, you could think about all these things as being on continuum, and that they all are sort of integrated and interlaced and affect one another, as Dr. Miron was discussing earlier. So again, building that trust and rapport, and using that, and harm reduction, which goes back to what we talked about earlier, but something is better than nothing. And frankly, maybe the approach changes over time. Maybe you start with a harm reduction methodology and approach, and for some people that transitions over time to abstinence. But maybe abstinence wasn't something that was palatable or achievable to begin with. So meeting the person where they're at. We also, as we've discussed numerous times, thinking about a multifaceted, frankly, multi-layered approach that will be needed for therapy and medication management. We know that gold standard treatment for moderate to severe symptoms and issues related to PTSD as well as substance use is going to be a combination of psychotherapy, good, robust, standardized, oftentimes manualized psychotherapy, along with, where it's appropriate and patients are agreeable, the use of recovery medications for substance use issues, and medications to help with mental health concerns as well. And we know that the therapy oftentimes will be cognitive behavioral therapy and prolonged exposure, certainly for PTSD. But we know that dialectical behavioral therapy, DBT, is absolutely an evidence-based approach, and one that we integrate and use all the time. And I think the key thing here too is that we start with the evidence base, we start with the foundation of what do we know to be safe, consistent, robust, effective treatment. And then the reality is that we can still stick to evidence-based models, which we absolutely encourage. But I think we've got to meet the person where they're at. And so dialing in, dialing up, or dialing down exactly kind of what does a patient need? Do they need a little bit more CBT or prolonged exposure here? Do we need to really start with more DBT for grounding and distress tolerance to be able to move into prolonged exposure? That's where the art really meets the science, right? And that's where we have to work to find that delicate balance. With medications, oftentimes the gold standard will be selective serotonin reuptake inhibitors like a fluoxetine or sertraline to be able to help with mood, anxiety, PTSD symptoms and issues, recovery medications such as buprenorphine, such as naltrexone or acamprosate to help with alcohol use, opioid use, among others. Issues that may be coming into play, just really having a conversation about what's evidence-based, what's safe and effective, and really trying to use all of the tools that are safe and appropriate to address all issues at the same time, to really have a really solid and an integrated treatment plan is going to be really, really helpful. And then lastly, I would just say slow and steady. Slow and steady wins the race. That these issues often don't occur certainly all together overnight, all at once, and treatment will take time. These issues are not going to be resolved all at once overnight either, but definitely, as I mentioned before, we can see progress and gains early, and that we can help individuals to build momentum more and more over time. So this can be challenging work. This can also be immensely rewarding, effective work. And frankly, you can have a lot of fun along the way too, and being able to really connect with individuals to help them see change and progress, and to help them get back to living their lives, and doing the things that they love. So definitely, please, when you have the opportunity to treat individuals with these co-occurring issues, specifically PTSD and substance use issues, welcome it, embrace it, meet them where they're at, and take it one step at a time. So from there, we have time for questions, and so we can open things up and talk about frequent questions that have come up, and we will also talk about where to get additional information at these sites here in a moment. So time for some questions, please.
Great, thank you. Thank you both. This was really wonderful. Some questions that were submitted. First, what is your experience with PTSD patients who are suffering from opioid use or methamphetamine use, who have also developed a traumatic lifestyle around their use? How do you address this?
I can start us off. I think very much the approach that we've discussed and that Dr. Miron so eloquently laid out, in that, we need to address all of the issues concurrently. Again, addressing all the issues, I think the thing that we want to talk about there is also, while we're addressing the issues with regard to lifestyle, medical needs and concerns, mental health issues, substance use, it doesn't necessarily mean that you're going to address all the issues with the same tenacity and intensity all at once, right? But making sure that we are addressing those issues, especially with regard to safety, right? Sometimes individuals with significant trauma, PTSD, develop substance use. With that, they're not able at times to work a job or have consistent income. So then selling drugs can come up. Prostitution is not uncommon by any means. And so thinking about, hey, do you have a safe place to live day to day? Are you surrounding yourself with safe people? If not, well, let's also think about case management services. What are community resources that we can help you to either get into a shelter, live with family or friends, if even temporarily, right? Let's establish a safe environment, because if we don't have that, then it's going to be really hard to do these other components of treatment, right? You could really make the argument that if there's not a consistent place for a person to be and to be safe, prolonged exposure so vital and important, but we're probably not going to be able to do that. We're probably not going to be able to consistently prescribe medications if you don't have a stable phone or a stable place to be, a stable way for us to contact you, right? So we need to address all of those issues. And again, while it may be overwhelming or daunting, initially with well, we're going to address all this at once. Well, it's going to take some time, right? But we need to be thinking about all these things and integrating more and more over time. So those are my initial thoughts. Dr. Miron, do you have other things you would add there, please?
Yeah, I think I would add, kind of hearkening back to that review that I talked about earlier of randomized control trials, no wrong doors. So in this case, if somebody's really not experiencing enough stability to do something like prolonged exposure or cope, is there a way that you could still integrate discussion regarding their life or their trauma history and how that might contribute to the substance use that they are, the substances they're using now, or even, the fact that they might be at risk for subsequent trauma exposure? Can those conversations still be integrated into treatment, even if it's less formalized? And then just the other caveat I would want to add is, depending on the patient's level of use or what they're using, medically supervised detox or any other medical emergency would certainly need to be addressed and stabilized before anyone would begin some kind of integrated program. So this might be a good opportunity to assess whether that patient is medically ready for something that's like an integrated treatment. And there are a few instruments you could use to help with that as well. The CWA, for example, but certainly the integrated model is preferred, but there may be cases where that might need to be deferred if there's not a stable space to get treatment or medical instability.
Thank you. Are there specific integrated treatments targeted to adolescents?
Yes, absolutely. There are a number of different integrated treatments. So we think about ACRA is certainly a community-based model and approach. We think about multisystemic therapy, MST treatment for adolescents. That's, those are typically specific to co-occurring mental health and substance use issues. Certainly it applies to trauma as well. I think the overall, there may not be one kind of be all end all treatment model for adolescents or adults, but rather systems that are able to take the important components of being able to utilize supportive therapy. Family therapy is often a quite beneficial and important model. Cognitive behavioral therapy, dialectical behavioral therapy, prolonged exposure, motivational interviewing, right? These are going to be the pillars that form the foundation of psychotherapy that we provide, because again, we're not oftentimes targeting just one issue per se, right? So we've got to address all the issues and the different facets that come into play psychosocially and how that affects someone's trauma and their recovery, in addition to substance treatment. In addition, definitely depending on the type of substance use and the age of the individual, there are some recovery medications that are approved for adolescents, down to age 16. So certainly that is appropriate. Addressing mental health issues with medications, there are a number of FDA-approved, evidence-based medications to treat trauma, anxiety, PTSD, depression. Sleep is oftentimes a major component that comes into play, because just as Dr. Miron mentioned earlier, these individuals oftentimes will experience trauma symptoms, not only while they're awake, but especially too while they're asleep. And so, they're not able to ever get reprieve or some rest. And that's going to be really important too. I could go on, I get on and on. I guess I would say also just thinking about community support, educational support, thinking about getting integrated into job and working if that's appropriate for adolescents, also sports, religious affiliations and community supports there if that's appropriate and something that resonates for them. And then definitely when we think about diet, exercise, overall wellness there too, those are all really important factors that come into play.
Thank you. Before we conclude, I would like to ask you to share any specific recommendations or additional resources that our participants can go to learn more.
Yeah, absolutely. So I'll highlight one resource I mentioned earlier when we were talking about assessments, and that's the U.S. Department of Veterans Affairs National Center for PTSD website. It is from the VA, but it's certainly applicable to civilian patients as well. Lots of great resources, including many of the assessments that we discussed earlier, but also videos for patients, how to explain what PTSD is to somebody, how to involve a family in care. If you have a family member who is going to be embarking on prolonged exposure or integrated treatment, for example, what can the family member do? What can they expect? So a lot of great resources on the ptsd.va.gov website.
And we just have some information about us. I think that's really the conclusion of our presentation.
Great. Well, thank you again, Drs. LeNoue and Miron, for taking time away from your clinical practice to share your valuable insights. Helping a patient on the road to recovery means collaboration among everyone involved in their treatment. With locations across the country, our treatment teams are ready to partner with you, and Rogers Outreach representatives are happy to answer questions regarding our treatment services, as well as learn more about your practice. On behalf of everyone at Rogers, we look forward to partnering with you to help support your patients. Thank you.
Thanks, everyone.
Thank you.